So in fact, let me tell you at the very outset that ELCA is not the primary device for calcific lesions. It is a good device for in-stent restenosis. So I'm going to share with you all my experience and the data which we have for ELCA in ISR lesions. So since we already know that complex lesions are coming our way all the day, and we see all these complex lesions being treated during the live cases also. So where do we do laser or ELCA these days? So in balloon uncrossable lesions or resistant lesions, complex lesions, vessel preparations where we were doing bioabsorbable scaffolds, ISR preparation for either a drug-eluting balloon or a drug-eluting stent before doing that to take care of the new intimal proliferation. Because we still do not have a final answer as to how we treat new intimal proliferation. And then, of course, thrombus in acute MI and also in occluded vein grafts, it has shown some good outcomes. So this is the catheter which we use, which uses the light spectrum. And when we do this, definitely, there are certain issues which we have to keep in mind, that we have to keep flushing while we are doing the laser, advancing at a slow speed, and then controlling the fluence. Fluence means energy, and the pulses means the speed. So that we control. There's the console, which I'll show you, and this console controls that. And the vessel to ratio, the catheter ratio. Generally, the 0.9 catheter is good for most of these patients. So typically, 90% times you will be using a 0.9 catheter. So there are 1.9, 1.4, 1.7. But 0.9 is very safe, very good. So ISR, of course, ISR is something which we still do not know what is the best treatment for that. We still are trying to grapple with this problem, and it is still existing, despite all the best possible drug-eluting stents. So how do we treat that? So I'm just showing you some cases. And this is a patient who comes as a young patient and has a very nicely done stent to start with. And when he comes to us, this is the situation. This small, very small stent that also is restenosed. And this can happen. We see that. There's nothing new about it. So how do we handle this? This is a young patient. So should we put another stent here? There will be 2 stents. If he has a restenosis, there will be 3 stents. So we have to make a plan so that in this young patient, we treat it without a stent. So in this kind of situation, our dominant strategy these days is to do a laser ablation of this new intimal proliferation, and then followed by cutting balloon, which is a Wolverine these days, and followed by a drug-eluting balloon. So these are the kind of results. This is a fairly simple case, I must say, where we can use this technology and get good results without putting an additional stent. So that was the premise on which we used this device initially. Then, of course, we have other kind of cases, as you can see here. Now, this is a slightly more complex situation where you see that there is a stent here in the middle. And this stent is basically, partly it is okay, there is some restenosis, but proximal to that, there is a tight stenosis. And it is going up to almost to the ostium. How do we treat this? You can put another stent, but before putting a stent, definitely we need to debulk this because this patient is needing, because the vessel is not too big, it is about 3 millimeter in size. So we do debulking with the laser and followed by again a Wolverine, and then followed by a stent here in the proximal segment. So this is how we can combine the effects of these technologies together to get the best outcomes in these kind of situations. Then, of course, you can see a vein graft like this. And this vein graft was very tight. This patient is having acute, coronary syndrome. So how do we handle this situation? So in this, even putting a wire was difficult. So wire was put, the balloon is not crossing. So how do we do this? So we put a laser here, we lase it, and followed by laser. So what laser does is, it takes care of both the stenosis and also the material which is inside, the degenerative material in the vein graft. And that also, maybe, this is what we have seen. We do not have a randomized controlled trial on that, how it compares with the distal protection device. But in this patient, we didn't use any distal protection. We did a laser, followed by a stent implantation, and we got a good outcome with no slow flow, etc. So this is another application which we do, especially in these kind of situations. Now, this is a kind of patient which is very, very bad patient. Here you see, this patient already had 2 stents, and 2 times actually. And so this is a 2 layer of stents up there, and there is 1 layer of stent down there. So what do we do in this patient comes again? So in this patient, definitely, we cross this lesion with a, I think this was a Felder XT wire, followed by a laser. So we did the laser catheter moves down slowly, and then followed by balloon inflations. And after this, we find this kind of outcome. What do? No more stents. So here we do more dilatations using, again, 1-to-1 balloon using cutting balloons. And these are the laser runs, which we do again. And then finally, we were able to get a very good outcome here, very good flow in this entire RCA. And then what we do is we do a drug-eluting balloon from bottom till up. So these are 2 or I think 3 drug-eluting balloons, long balloons, because the longest is 40 only. So we used, I think, 2 or 3 balloons here. And here we can see that this is and we do about more than 1 to 1.5 minutes inflation and get very good results in these kind of situations, as you will see here. So this is the final outcome here in this case, which was looking quite bad. And normally we would have just put some more stents also. Finally, in some very more difficult situations like this, here you can see that there is a left main which was stented. Left main to LAD and circumflex bifurcation stenting has been done, and this patient comes with an in-stent restenosis. How do you treat that? You can't put more stents here. So we again try to first, wiring was an issue here because you have to go from the main through the stent, not from the sides, because the stent is hanging outside the left main. And this is a thing which can happen. As you can see here, even the guide was not really helping us. So we tried to do some maneuvers, tried to do wiring from little away, and then did wiring to both the LAD and the circumflex. Did IVUS to check whether we are in the true lumen or from the side. So we confirmed that yes, we are okay. And then after that, of course, we started doing this laser. This is, I think, some mix-up here. And so we did initial dilatations followed by laser passage into the circumflex, and then cutting balloon, and then followed by drug-eluting balloons. So here you can see that we have to treat this with drug-eluting balloons, 2 drug-eluting balloons, LAD and circumflex, and the final result looks quite effective and promising without putting any additional stents, and this patient is doing very well. So basically, this is some kind of I must say, a hypothesis which is generated now, and using these technologies together might help in-stent restenosis, and the data is there. Some data has been already there. At the end, I must say, why use ELCA in ICER? Because it is effective, it is safe for debulking, it has a potential for greater vessel and stent expansion, potential for additional stent placements if required, and distal embolization also is reduced in this kind of situation. So I think, in in-stent restenosis, definitely it's a very good additional adjunct tool which can help getting better outcomes. But for calcified lesions, in the end, I must say that it is only for mild to moderate calcific, fibrocalcific lesions. If nothing is crossing, you can use to cross the lesion. But definitively, therapy has to be done with either a shock wave or a whatever you want to do, cutting balloon, etc. Thank you very much.
Excellent talk, sir. So the previous case they mentioned, so such kind of under-expansion, there is any data with such laser use in such patients?
Yeah. So basically, we have to definitely identify what is the reason for this in-stent restenosis, whether it was a heavy calcium which did not let the stent expand. So if it was an inadequate stent expansion to start with, you have to do with either a rota or a shock wave. But if it is primarily new intimal proliferation, you can do this.